morning, everybody. Thank you for coming to such an early meeting. It's my honor and privilege to introduce Dr. Uttam Sinha. He is Medical Director of the Head and Neck Surgical Unit. He is Associate Dean of Surgical Innovation and Simulation, and he is a Watt Chair for Head and Neck Cancer Research. He's been here at SC since 1985. He is a huge supporter of comprehensive rehabilitation. He refers many of his patients to speech and swallowing, PT and OT, so that leads into a natural fit for his interest and research in integrative health.
Thank you, Vanessa. Good morning, everybody. Thanks for having me today. We are doing this for many years, so I thought that maybe it was a good time to share our experience, because somehow directly or indirectly all of you are involved in our cancer patient care and research. So let me start with the story. So Tara Enos, who's 38-year-old, she came to us from UCLA. She had a neck cancer, and this was the UCLA scar, this is the USC scar. So they opened the neck, saw that tumor going into the chest, and decided not to do anything, and they told her that get lost or die, can't do anything. So what she did was she went to Mexico and for alternative complementary treatment, and got all kind of treatment, finally came to USC, and somehow I thought that we can take the tumor out. And I cannot tell you how, but somehow I felt that we can take the tumor out, mostly because of our expertise, multidisciplinary, and because of our rehabilitation we do. So I talked to Tara in great detail, so then we had this multidisciplinary approach. So we McFadden opened up the chest, I took the tumor out, and then this is the aorta, this is the subclavian artery right there, carotid artery. So basically, we had to take the subclavian artery, and Fred Weaver, our vascular surgeon, he put the saphenous vein graft. And here's the close-up view, and we close the chest, and this is the story. So while she got discharged last week, but before she got discharged, she said, no, we should get engaged. So she got engaged with her boyfriend, and I had to be there with her at the engagement party. So this engagement took place on 5 South, and the week before she had death sentence, and week after she got engaged to her boyfriend. So that's the story.
Bravo.
And the good thing about this story is that it happened because she believed in us, she believed in our global approach, and more than any other institution in the world, probably, and because we could execute. It happened. That's because it happens because we have this team. That's it's great goes to all of you. So this is what we practice every day. We just not WHO, World Health Organization definition of health is physical, mental, social, and possible spiritual well-being, and not a mad absence of a disease process. So we really, really believe in that and practice that in our day-to-day practice, just to improve the outcome. And that's why we talk about the diet, exercise, lifestyle modification, just not the cancer stem cell or nanotechnology. So I think that some of these things are, you have to have unconditional love and support for probably the most powerful healer. And love means service. Yeah, last week I went to a retreat, and this monk came from the Himalayas. He was talking about, there are 4 things you should do. One is fellowship, the company you keep. Second, that will improve you, will bring you up, not pull you down. Second is service. Serve with love. Whatever you do, if you give a cup of coffee, give with love. When I do surgery with the residents, I tell them that make sure this is the best knot in your life when they're suturing. Then is study that will improve your wisdom, and 4th is meditation. So you're saying if you do those 4 things, then automatically your life will be smoother and you can overcome a lot of obstacles. And I personally believe that because I practice that. So that's love. So I think that because all of us have innate healing properties, and we look at the patient as a person, not a disease. And so treatment involves fixing the cause, not the symptoms, and it's a team approach as we are all here today. So this team approach, and we have this excellent team. And look at how many people are involved, how many disciplines are involved into the entire care of the patient. And I can name at least 1, 2, 3, 4 persons from each category listed here, and all of you are here. So this is the team approach. And of course, we have a patient survivor group, and they have this motto: beginning of a new normal. So they went through surgery, chemo, radiation, all those things, but now it seems like they're more healthy because they're doing these things. They're eating good diet, they got rid of smoking and alcohol, and they gain confidence and faith because they are not survivors, they conquer of cancer. So they have now confidence and faith, and they now know how to manage their stress, and they also do breathing exercise. We teach them how to do breathing exercise to reduce the amount of stress. So we do all those things for cancer management. And this is another story. Mike and Cynthia, this is our sign for our head and neck cancer support group. So they are traveling all over the world, and they're carrying our message to all over the world, basically. And he was so glad that he's there. He sent me this email, this picture, a couple of weeks ago. So what we do for head and neck cancer today? So we do. So we'll talk about, this is what we do, management. We'll show us different types of management, rehabilitation, and what we are moving forward. And this is going to happen next year probably. Early detection from saliva and prevention of relapse probably by targeting cancer stem cells. Another example is a tumor on the left side of the tongue. We reconstruct by taking tissue from the forearm. It's called radial forearm free flap. So this is the native tongue, and this is a reconstructed area. So the native tongue is strong enough to move the tongue back and forth, so patient's speech and swallowing would be quite good. And I can show you how good it is. This is, she is cancer free. This thing never works. This arrow. So I don't know whether you can hear it, but anyway, so her speech is good, basically. Probably you can hear a little bit. And here, she is eating hot dog.
Is that on the healthy list?
She didn't say. Anyway, so she can eat regular diet. So we challenge ourselves. We are doing collaboration of across the institute, across the university. We're working with the bioengineering. We challenge ourselves how good our reconstruction is. So the School of Engineering, they came up with a new protocol which goes with our, see how the tongue moves, how the soft palate, postpharyngeal wall, all the structures are moving in a real time. So when we reconstruct, so this gives us feedback how we should reconstruct. So this is a good reconstruction. Good reconstruction is we try to do the same reconstruction, is how the patient heals and what's the effect of radiation post-op. It depends on that. But this gentleman, he had the same reconstruction, but his anterior portion of the tongue shrunk because of radiation, and then his speech is much worse. So to overcome all this, we are also doing minimally invasive surgery with the robot. And we got FDA approval for head and neck cancer surgery in 2010. And it has, just briefly, it has 4 components. It has surgeon console, patient side chart, endorsed instruments, and vision system. So this is the surgeon's console where surgeon sits and performs the surgery. And this is the side chart, this is the actual robot, if you will. And it has several arms. And the instruments have similar movement like the wrist. and these are some of the closer. And this is a beautiful vision system. This is a 3D camera, HD, and this is the setup where the camera is going inside the mouth, and this is one arm of the robot, this is the other arm, and this is the overall set.
That's the long view down
Yeah. Sure. But we are working with NASA also. Seriously, how to navigate the body. So that's another project going on with JPL and NASA. So this is how it works. So the surgeon is sitting in the other room or very far away, and how this we're doing. A patient had cancer of the left tonsil, and here is the last molar tooth. This is the tonsil, palate, uvula, base of tongue, endotracheal tube for anesthesia, and the robotic arm is cutting the cancer of the pharyngeal wall. So these patients, good thing about these is that the patient goes home next day on oral intake, and they, so the length of stay is much less. So that's a good thing, because before I have to reconstruct this pharyngeal defect, because there will be a connection between the pharynx and the neck, so you have to have a watertight seal, otherwise patient will have salivary fistula. So with this, we don't have that.
So, the question, before Da Vinci was the limiting factor your hands and getting all the instruments
No,
in there?
because the instruments were bigger, because they were originally designed for the chest and
Chest.
the abdomen,
Uh-huh.
because all of these endoscopy stuff, they come from here, and it's easy to work in the big cavity as opposed to neck or head and neck area, which is much more compact. So this is the prevertebral tissue where I'm removing there, and then finally the cut will be along the base of the tongue, from medial to lateral. So the point is that again, if the overall quality of life has improved, much less blood loss, and length of stays, so the recovery is much better, much faster, and they go home sooner. So there is a justification why we used to use robots, which is cost $2 million to do this. Probably we can justify, and also share the robot among or around urology and OBGYN, thoracic, so all of us using the 2-3 robots. So rehabilitation. So our rehabilitation program, whenever we see the patient, it's mostly speech, swallowing, and physical therapy and OT. And also we have, as we saw, the other areas. But those are very intense. So Noriko, Marisa, Kimi, all of them are involved. Then Linda, then Madhavi, of course, Brenda's, and Melody, they're all heavily involved. Now we thought that we wanted to see why does it work, rehabilitation. So, as you know, during radiation there is a tremendous trauma to the neck, and there's a lot of cytokines, inflammatory molecules that accumulate. And usually I take the muscle biopsy during surgery before we start radiation, and we did the microarray and identify what are the genes that could be upregulated or downregulated. So we targeted two genes, TGF-beta and MyoD. And here is the story. During radiation, TGF-beta goes up, it activates MAT3 pathway, which has anti-MyoD effect. So the MyoD expression goes down. MyoD is a very important gene. It has a helix loop, helix configuration, and it maintains the phenotypic expression of myoblasts. So if you take the gene out, there will be phenotypic expression to fibroblasts. So basically, muscle cell become fibrous tissue cell, and vice versa. It can go back and forth. So when there is a MyoD deactivation, there is more scarring. But when I do rehabilitation, so this is normal, and this is radiation. There is much higher expression of TGF-beta. But when I do rehabilitation with exercise, electrical stimulation, see if there is more normalization of the tissue. We also looked at the protein amount of MyoD and TGF-beta. If normal, this is the normal row, and this is the radiation row. You can see TGF-beta is high, MyoD is low. But when you do the rehab, the TGF-beta goes down and MyoD goes up. Well, there is more normal restoration of this muscle. So this is the story that now we can even have we maintain the molecular homeostasis in the neck by doing electrical stimulation and also exercise, of course.
What's the time course for it? What's the time course?
This about 3 months. So 3 to 6 months post-op, post radiation. So we got excited. So we wanted to use this implant biome, which a lot of you are involved into this, and we got the FDA approval to place this implant. This is a very complicated thing. I'm not going to go into detail. Basically, this is the hypoglossal nerve on the left neck. We place the biome of this stimulator, microstimulator, just above the hypoglossal nerve. After the answer takes off, because answer goes to the infrahyoid muscles, and we don't like to stimulate the infrahyoid muscles because that will pull the larynx down. So we need the suprahyoid muscle, because when you swallow, if you look at my Adam sample, it's pulled up and forward and then gets stuck underneath the tongue. So that's how we would prevent aspiration. So we need to let the larynx go up and forward. That's why with the aging process, there is larynx, like everything else, larynx also sags. So that's why patients have more aspiration pneumonia, because larynx is not here, larynx is above the chest. So that's why the excursion time is the same. So we're trying to do a bigger trial with this. Now we got the FDA approval to do head and neck cancer, but eventually it will be injectable, and you don't have to open up the neck, and you can under the ultrasound guidance, you can identify the carotid artery and the vagus nerve, or the hypoglossal nerve, and place this implant just above that. So, and patient then wears a coil in the form of a collar, which is connected to a handheld device, and this coil sends radio frequency to the microstimulator, and that gives exercise to the tongue and the pharynx. See, a patient can read newspaper, watch TV, and the exercise will continue on the time. So this is, and we optimize the patients. Welcome.
Sorry, coming so late.
Oh, that's okay. So all these things, we see how this multidisciplinary approach resulted in multiple publications, presentations nationally and internationally with PT, OT, speech, swallow. This is some of the examples. There are probably hundreds of those. So where are we going from here? So number one is early. There are two things we can do. One is if we can do early detection of cancer, that's huge. Like you can see the success of mammogram and pap smear. But for head and neck cancer, there is no such thing as for early detection. So my dream is one day we will take this to the villages of Asia and Africa to detect early this cancer and save millions of lives, because the incidence of head and neck cancer is number one in Asia and Africa, mostly Asia, especially Southeast Asia. So early on, since 2000, we are working on this early diagnosis of cancer from saliva. So this is very early data. At the first cohort was 32 patients. We took their serum and saliva, and I looked at the IL-8 and IL-6 and a bunch of other genes, but always IL-8 stood out as the most important candidate, and it showed the good sensitivity and specificity. And working with Rich Robert in the Department of Chemistry, he has this new peptide which is called mRNA display. You can produce your peptide on the table. You know the sequence of your protein to detect your target. So basically, this is the like antibody. It's called monobody. It's much smaller. Antibody is about 11 nanometer, whereas the monobody is about 3.4 nanometer. And we impregnate. We are using this now to detect cancer. And this is a future device where you can put a drop of saliva here, and you can see the reading over there. If it is less than 1,000 picogram, it's normal. All of us will have less than 1,000. And if it is 2,500, it's cancer. If it is about 1500, there is some lesion in the mouth. Could be sore throat, could be gingivitis, could be anything. Could be post-radiation, but it's not cancer and it's not normal. So that's very specific. So less than 1,000 normal, 2,500 cancer, something in between, that they should see a patient, doctor, to find out what's going on. So this is, we are taking we actually had a meeting with the Ministry of Health in India last month, and they are very excited. They want to start this as their national health program. So our biggest enemy is radiation, because radiation causes so much collateral damage to the normal tissue. So we are also trying to reduce the dose of radiation. We have all these fancy gadgets, IMRT, CyberKnife, but total dose of radiation is the same. Doesn't matter what instrument we use, the dose is same. So we targeted one gene, ceramide, which is on the cell surface lipid, and this is the pathway, ceramide and sphingosine 1-phosphate. Sphingosine 1-phosphate, I'm sorry, this doesn't show, it's called sphingosine kinase. So when the sphingosine kinase goes up, sphingosine 1-phosphate goes up too. So sphingosine 1-phosphate is the bad guy, and ceramide is the good guy. If ceramide is high, then the cells are more sensitive to radiation, whereas sphingosine 1-phosphate, if that's high, then the tumor cells are more resistant to radiation. So we thought if you block sphingosine kinase, and then probably the ceramide will accumulate within the cell and it will be more sensitive. So this is how it is. So tumor, radiation, cell death, tumor, high SPK, radiation resistant. So we did a clinical study and we found that the SPK is a good candidate, and so we decided how we can silence this gene. So we used gold nanoparticles to take this siRNA to the cell to silence this gene. And this is the cell. You can see the gold particle under the electron microscope inside. And this is a confocal microscopy. You can see that the yellow, this is the red is gold particle, green is siRNA. This is separated, but this is still in the process of separation. So it takes about half an hour to silence this gene. Then with working with, again, School of Engineering, we came up with a delivery of this siRNA at the site of lesion. And Ellis Lang is the PI of this project from School of Engineering. And we put this pump and took it to the tumor, and the pump gave pulsatile siRNA delivery within the tumor. And the mice gets whole body radiation. So the site which is treated, there's a 98% reduction in the size of the tumor with one dose compared to the other side. So this could be a target for radiation reduction, but we're also working on some other areas. Now, another biggest problem we have is that no matter what you do, 50% patients are going to be alive and have decent quality of life, but the other 50% are going to die. And we don't have any biomarker to detect who's this good 50% and who's the bad players. So immunogenicity, all these things. So probably the reason is that there's a theory which was described in 1955. It's called field cancerization. The entire upper airway digestive tract, because of the trauma from either smoking, drinking, or viruses, they're all traumatized, all those cells. So they are all there is a potential of all those tumors converting into cancer. So although we've taken one cancer say from a left tonsil, we have many patients who had, after 3 years, he developed a second cancer on the right tonsil, or third cancer in the tongue, fourth cancer in the flora palate. And I'll show you some picture. We have a champion who had 5 cancers still alive. So the point is that because of the field cancerization, and one theory is probably the cancer stem cell theory, because the stem cell maintains all the tissue. So the adult stem cell. So there is cancer stem cell also called tumor initiating cell. It has a cell renewal capacity, it has a differential potential, and it's present in a wide variety of cancer. It's not cancer specific. And it also makes the cytotoxic agents more resistant to treatment. If there is a high number of cancer stem cells, probably those tumors are more resistant to chemoradiation. and probably they have a higher chance of relapse. So this is a concept you should remember. If it is stem cell divides, this is a normal differentiation, which is called asymmetric differentiation. Means one stem cell is dividing in one stem cell and one mature cell, and this is the further division, and two mature cells come up. So see how the system is well designed, well controlled. However, when there is a mutation, this stem cell will divide into two stem cells. Then this stem cell, if we are lucky, will form one normal cell, but have another cancer stem cell. So then the system becomes very chaotic, and there will be endless, ceaseless multiplication of cells, which go into cancer formation. So as I said, 50% will die and 50% will stay alive, because see, this is the regular cancer cells, and this is the cancer stem cell. It's difficult to kill the cancer stem cell because they are like polar bear. They go into hibernation during treatment, they don't multiply, and they don't get killed. And it's easy to kill these regular cancer cells. You use any drug, cisplatin, Erbitux, methotrexate, any drug, probably you'll kill all these cancer cells. But cancer stem cell will persist, and then it will come back one day. And if you're lucky, with that treatment, you'll be able to kill CSC, and the whole tumor will undergo degeneration, and patient will be alive, and this is a survivor. So that's the theory. So we are working on Vicky in our lab. Vicky and Agnieszka, they are our stem cell scientists. They are working on this several pathways. One of them is Wnt-signaling beta-catenin pathway, and we inhibit that pathway. And it has two other proteins called CVP and P300. Normally, CVP, beta-catenin, and beta-catenin P300 is very well balanced. But as we age, this side starts to go up. So if it is normally it's 1-to-1 ratio, with aging process this becomes 3-to-1 ratio. But in cancer it becomes 10-to-1 ratio. So it's all there's nothing specific about cancer, it's all about amount. So there's a higher expression of this complex, of this protein complex. So Michael Hahn, he came up with this molecule, and we blocked this pathway of the CVP beta-catenin, and then brought the balance back. And they just wrapped up a phase 1 trial in colorectal cancer at Norris Cancer Center. And they have, probably David knows more about this than I do. But anyway, so but you need another agent to kill the cancer cells along with this.
Yeah, we're definitely seeing responses as a single agent, so we've seen
Responses.
some responses.
So we are second in line because we have enough data that it also causes sensitization of the radiation. So thinking we are starting a new clinical trial at Norris, that how we're going to use this during cancer treatment, so that ultimately we would like to reduce the dose of radiation, and also those patients, those 50% where the tumor came back, and you cannot give them any more further radiation because they already maxed out. You can use the drug and still give some amount of radiation, and then a small amount of radiation still be more effective in presence of this drug, because it will make the cancer cells more sensitive to radiation. So this is going on clinical trial. Just for fun, I put this picture because this drug is the same age to miles from 6 and 8 months. So this drug, which as I said, is not cancer stem cell specific. It's stem cell specific. It works on all stem cells. So there is rejuvenation. Look at the skin. So this guy got both of them had chemoradiation, but see the skin, how good, nice the skin is. So now they have this cream. You can get it and put it on your face, especially for female. Rejuvenation. So see the acne. Anyway, so there has been tremendous advancement in quality of life through rehabilitation, robotic surgery, to microvascular free flap, but unfortunately the death survival rate hasn't changed over the last 3 decades. So right now we need that paradigm shift more. We're going to do early detection of cancer from saliva, and we'll do this cancer stem cell directed therapy for prevention of recurrence. And I'm pretty sure with those two we'll will save millions of lives throughout the world. There are many, many, many people involved in this research, and this is our patient support group. And I started with Tara as a lecture, this is how Tara survived. And Lauren had 5 cancer. The last cancer I took out from the foramen magnum. So it was crawling along the paraspinous muscle from the foramen magnum, and 5 years ago, and he's running a marathon. So this is the story. That's why I told Tara that we must do this surgery. But don't forget the green juice. Thank you for your attention, and I'll be happy to answer your question. Thank you. Yes, sir.
Thank you, Tom. That was really remarkable work you guys are doing. So my question is, since what we're trying to do with these, this breakfast symposium is really, okay, what are the opportunities? You're already doing some wonderful things. I know, with the support group, the green tea, I don't know. Well, I guess question number 1 is, do you have any research outcomes or research going on with those activities that you're doing, say beyond the the stimulator and the cancer stem cell targeting? So, because I just came from a conference in Chicago for the Consortium of Academic Health Centers, Integrative Medicine, and somebody said something that, one way to look at integrative medicine is as lifestyle medicine. And so you're doing it in that those support groups post-surgically. So I'm wondering if you have any research outcome there. And then second question, maybe related, is how researchers interested in integrative modalities, meaning, your mind body, your herbal, your green tea, whatever, are there opportunities in any collaborative way, or do you see any possible opportunities for that sort of research happening, maybe as alternate arms to some of the pilot studies you're doing? I don't know, just...
Yeah, so to answer your first question, that we are collecting data just targeting one thing, that the risk factor for head and neck cancer and coronary artery disease is the same pretty much. Elderly, male, smoker. So we're looking at the lipid profile, which we can quantify. So if they are, say, on green juice diet and losing weight, so whether we are monitoring that. So we're collecting data just to show that what's the impact of this kind of diet on or lifestyle modification on health. So the problem is always about resources. So we don't have that much resources. So the good thing is we are getting 2-3 people, new scientists, and the program, that was my retention package, development officer and another PA type person. So I already, we went through this, so we are going to collect this data much more rigorously for head and neck cancer patients, and also we're targeting a few areas, like right now we're looking at the lipid profile, that's it. Because it's hard to, cancer is such a complex disease that it's hard to prove that it's not about one thing. That's why we are all here. That so many different aspects of life will impact cancer outcome. So probably one area is the first question. Again, we're collecting data, and hopefully we'll be able to publish. And second is, we love to collaborate with all of you. And in fact, we are doing it, like with Marisa, Kimi presented 2 papers in Las Vegas and somewhere else. And Brenda presented many papers, Melody presented, Linda. So all of them are doing, but we are not doing in a very organized fashion where we can submit a grant. These are good because this will go to support our collaborative nature, but I think we have to be a little more organized and do a more organized fashion.
One of the things that we have discussed at numerous times amongst our group is how to organize our activities in a way that not only we can present them to the community, but allow fresh blood to come into our group and work on these projects. And it's always difficult for a group like us when we're just getting started and our funding is really limited to just getting us together and talking. but not going beyond that. You know, we'd love to see more infrastructure where we can tie together, help develop common databases, so what you're doing and what someone might be doing in neurology can somehow or other inform each other. You know, what scales you're using, what tools you're using to look at quality of life, you know, what are the innovative features you're bringing into your research, things of that nature. And so this might be a good opportunity for us to think about getting a working group together to tie together all the different things that we've heard over the course of these. You know, you're doing some fascinating work. It's highly relevant, directly applicable. You have a wonderful patient
We have to have
population.
a working group, and we should meet once a month. Otherwise, once a year lecture is it's okay. But I think we should meet once. We should have a group, and this is a group meeting, like the way we do it in our research meeting once a month. So same way we can meet once a month would be great.
Yeah, I mean, just fascinating stuff. But I was wondering, given the tremendous interest now in personalized medicine, and as you say, you know, this is a highly, highly complex, incredible number of variables. What work is going on either in your lab or others looking at identifying a specific endophenotype or SNPs or something, so we can have something more in a biomarker that might give us some insight into effects on interleukins? And is it just IL-8 or is it a secondary effect from other interleukins that might be a downstream effect? Because to me, that's taking it kind of to that next level as opposed to this one-size-fits-all, which I think really ties into what a lot of we're interested in here in integrative medicine. How do we identify something that's best for this patient given their unique endophenotype?
We looked at interleukin more closely, IL-8, because there's a phenomenon for those who are not in science. It's called epithelial mesenchymal transition. The epithelial cells, the lining should go into fibroblast, and the fibroblast produce a lot of product that goes then facilitate migration of the tumor cells into the blood vessel. Just the crosstalk between the cancer cells and the endothelial cells, crosstalk between the cancer cells and the fibroblast, and the crosstalk between the T cells and the cancer cells. So these crosstalks are so complex. There are thousands and thousands of crosstalks happening every moment. So how we can, what can we do to understand those? So it's so complex. So we saw that the IL-8, because we cannot do all of them. It's impossible, at least at this point. So the reason we looked at IL-8 biomarker, because that has been consistently always high, and it's also produced by the cancer stem cell, and also it's responsible for epithelial mesenchymal transition. So that's why it's not just inflammatory molecule anymore. It has much more, because as we are understanding more and more, it's much more. So same way, as we continue to explore, there will be more and more molecules that will come out, but there will be not a single molecule. Eventually there will be a cocktail of molecules that will determine the overall outcome. And it may not be that. Again, those molecules are there, but if the patient starts to do exercise and green juice, the molecular environment will change. So we cannot neglect the other aspects. So there will be always so variable. That's why it seems like always is infinity. That's why we should do all these things together, because that will have overall patient outcome and patient satisfaction, and cost of care will be much better as opposed to the way we are doing things now.
To go back to Debu's point and what you said, Debu, this might be a really good opportunity, and I think it's an overlap between our institute's clinical group and research group about, because there was a lot of talk at the consortium meeting about practice-based research network, and I think you know that the consortium has funding from the Bravewell collaborative that actually funded the start of it. For those that know, the consortium is a group of now 57 academic health centers across the country. Canada just voted, and University of Toronto just joined. Academic centers looking into the role of integrative health, and a lot of the conversation was about, in the research group at the meeting, was about, you know, we got to move along with double-blinded research, you know, randomized controlled trials. What are other ways to show effectiveness, both in terms of cost and in terms of patient satisfaction? So this is a group that's going to be reaching out in the next years for universities and academic health centers to be part of that network, developing those common outcomes. So this idea of developing a working group, maybe overlapping between the clinical group and then the research group, George, that really, you know, hooks in with that effort. The guy that's running it is at Minnesota, so that USC, we can start to position ourselves to be part of that, you know, national and really international group. And we can start to develop a database here that everybody who's in practice at USC is collecting the same lifestyle outcomes, the same
Yeah.
patient satisfaction outcomes. So
We
should
should,
really look at that.
we should get the common data elements from BraveNet, I think
Yeah.
that's what it's called, right?
Yeah,
So that we can start integrating them here, because eventually if we could actually contribute to it. But it'll also allow us to look across our own research programs. If we all agree to contribute some small amount to this database, again, all of this takes time and effort and money ultimately.
Right.
But I think at least anybody who's doing research in this area should be aware that we are trying to get common data elements together. That might be the first thing to do. We applied for a CTSI infrastructure grant to do that, and we didn't get funded, but you know, I think that would be a start.
So that's, CTSI is actually what I want to talk about. Do we have a representative of CTSI in this group? And if we don't, we should be agitating to get somebody who is in that group to be-
Holly was supposed to be here from CTSI, and actually someone else from CTSI. Don't remember their
So I
name.
think, you know, we've got a number of studies that haven't been funded because we're not meeting whatever their moving target is. But if we can get somebody there to consistently participate in this group, that maybe they will see how we can move forward as a university and really have them do a seed grant to even fund somebody to collect the data from all the
Yeah,
different.
well, we did submit an infrastructure grant, and the critique we got is that it didn't have enough clear sense of what the specific research projects are, which I didn't think it was, you know, obviously when you're submitting an infrastructure grant, you don't provide all the details of your research. But I'm thinking that maybe we do need to actually have a list of actual funded projects. I think that's what they wanted to see. They wanted to see if they were gonna throw money into our database, that at least it's supporting funded projects or projects that are likely to get funded,
that's-
which makes sense. So I think we need to maybe reverse engineer this next submission and actually start with funded projects and see how we can tie them together with a database.
Yeah, that's the key. I've had a couple CTSIs and now I help review for them, and their key thing, no matter what they say, I'm not part of it other than I review for them, is what has the greatest likelihood of showing immediate return on investment,
Yeah.
because they're coming up for review very soon.
That's right.
The feds have dropped a number of the CTSIs. They're gonna refund those that have seeded projects that have gone on. So you might have a terrific idea, but if it's gonna take 5 years to get a payoff on it, you're not gonna get funded. If you can have a so-so idea, but you're gonna get return, you're gonna get something in return, whether it's papers or additional grants, within a relatively short period of time, you're likely to get funded. So I don't care what they say, the bottom line is quick, and I don't blame them because it's their own survivals at stake, but it's quick, it's rapid return on investment. So as the booth says, the more structured it is, the more, I mean, it's almost like, you know, you're only gonna lend money to people who don't really need the money. So you have to be, so you have to have something that looks like it's really tight, and that this is just gonna help give you that extra little push that you're gonna have 3 other funded grants or a bunch of other things. So that's a little from, not quite on the inside, but on the periphery enough to know what they're funding.
Well, that's why I think we should get them inside. You know, this is
Well,
a
but-
happening group here.
no, but maybe what the booth's saying, and George, maybe you can chime in, but if that next go
Yeah,
around for the CTS.
I think we need to get funded
CTSI
projects, see how a database then could generate new research
It could
funding with the
lead
new
to a
projects,
project- it could
but as
lead to a
opposed to saying,
project
hey,
that's
we're
going-
starting from scratch,
That's
we
right.
want a database to start collecting. I
Right.
think
Build
that-
on some
Yeah.
success.
So choose those outcomes, link to projects maybe that UTOM already has funded or others already.
That would be the way to go.
Funded and build that.
Piggyback onto
practice.
something that's already shown some
Right,
return.
right.
sure, please.
So, I wanted to ask you something. You said the risk factor for head and neck cancer is very similar to the risk factor for
Coronary artery.
coronary artery disease. Could you elaborate a little bit more on the green juice diet and losing weight? And then what are your measurable outcomes that
So
you're
we're
looking at in
just
reduction of
measuring
head
the
and neck?
weight and also looking at the lipid profile. So all the parameters like HDL, LDL, cholesterol,
And
and
the green juice diet is what? What is it made of?
it's very simple: kale, cucumber, celery, green apple, and ginger.
And how much do they have to drink of that a day?
That's one. If you want to lose weight, I have Seppi. You know Seppi? She's a physical therapist. I saw Seppi the other day, and after a long time, she lost 15 pounds. So she told me she went on green juice diet. She was drinking only green juice 3 times a day for 7 days. and didn't need anything else. Nothing else, water. So it's that powerful because all these micronutrients and antioxidants, they go directly to the cell, bypassing all these digestive system. And she's fine. So, in fact, did you see that documentary? It's called, done by an Australian guy, called Sick, Fat, Sick, and Nearly Dead. So he was 400 pounds, and he was a very intelligent guy, rich guy, going from doctor to doctor. Each doctor will treat hypertension or diabetes or arthritis, so he got tired of that. He said, I'm going back to Mother Nature. So he started to do juicing. 60 days he did, and he lost 100 pounds and got rid of all the symptoms. So he got so excited, he came to Midwest, and he started was a truck driver who lived on hamburger. So with truck drivers in Midwest and improved health of quite a few. And then he made this documentary called Fat, Sick, and Nearly Dead. It's really encouraging how powerful this food is. Simple thing, very inexpensive, way to lose weight. This is all these diets we're spending hundreds and thousands of dollars.
I do an international food show which touches on what you were saying, and we have a segment on all about cancer. And you can get as complicated and as intricate as you want about cancer, or you can be much more holistic and simplistic. The bottom line is acid versus alkalinity. And
Cucumber is alkaline. Cucumber is alkaline.
Yeah, and
And,
physiology. Cancer cannot exist above about an 8.0 or 8.5 alkaline scale. It just cannot exist. It's almost like our physiology or our body going into an environment that's completely toxic. The environment is horrible. The air is rotten. We can't exist. We can't stay there. It's very much the same with a cancer cell.
Eating good diet is a really serious project.
Right.
More serious than getting a CTSI grant problem. Really, it's really, I mean, I am so frustrated, so I finally got a butler, she was a female butler in his house, the person who makes green juice for me in the morning and good diet. So I'm eating and drinking because I felt sick a couple of months ago from several trips from East Asia coming back and doing all this long surgery. I said, I have to take care of my health. So I'm doing that first before I can help anybody else.
Good.
So I
That's great.
started doing that. So I began, it's really a project to eat something good. You go out here, you can find it. Donut, coffee.
If you do have green coffee,
Green coffee is good. The green beans,
right?
they are, Dr. Oz, I think, show. Green beans coffee. Anyway, thank you very much, and it was great.
Great.
Before everyone leaves, I just want to make an announcement, so you're all thinking about this. Save the date if you're interested. In May 13th through something, there's going to be an international research conference on integrative health and integrative medicine. It's going to be in Miami, Florida, right? Miami. So if you're interested in what's happening within the world of research and integrative modalities, that's going to be the place to be, is in May.
You have a flyer under your notes, if you can pass that out.
Oh, I do? Oh, I did, okay. And
Maybe.
also, in terms of more locally at USC, I just wanted to, Armity, do you want to just make your announcement about steps forward in medical school education?
Sure, yeah. So at USC, we've got approval for the fourth-year medical students to do a fourth-year selective, which is 4 weeks long, and we're starting in December. So we'll be taking 1 or 2 students at a time who are fourth years, and we were looking to partner with some local physicians or something. We've arranged for them to do integrative medicine outside the campus, but I thought if projects are ongoing on campus, that the students could come and either observe the physicians and seeing what kind of integrative approaches are actually being practiced on campus, whether it be, acupuncture, any kinds of spirituality. So we're working collaborative with the undergraduate campus as well as the medical school. So if people are doing, yoga therapy, anything that would be of integrative nature that fourth year students could connect with, if you could contact me, that'd be appreciated, and I can plug them in. It's starting in December. We'll be taking 1 or 2 students at a time. And actually, there's a higher demand, but we can't accommodate that many students. So I'd love to collaborate with anybody who is interested in teaching fourth year students. Thank you.
And lastly, please make sure you check in. I got your email address and add you to the mailing list if you'd like to be added to the mailing list. And Kristen here is our representative for our students for PT, medical, OT.
Anybody else?
Any of the students who are interested in integrative health, please contact Kristen as well.
What's the date of our next breakfast,
It's not finalized. It will be up. I will send it soon.
In December?
In December. Yes. Thank you all for coming.